I'll just get started. So thanks everyone for coming. Welcome to our, I think this is our fifth session, sixth even, fifth, bare bones on spine. So working our way around the body slowly. A couple of announcements quickly before we start. So usual housekeeping, if you've got any questions, please ask it in the Q&A box and make sure you do feedback at the end. We've still got registration open for our virtual congress this year, which is running in July, with our pre-congress courses on the 5th, and our which are running in person at the Royal College of Surgeons in Edinburgh, and our actual congress running virtually online with a in-person day focusing on medical students on the Wednesday. So these are the flyers for our pre-congress courses. We've got an excellent day of Viva courses run by Postgraduate Orthopaedics and the ST3 bootcamp run by the BOA, and they look to be fantastic days. So if you're interested in either of those, please register. There's more information on that website. And this is the advert for our medical student day. So we've got some excellent consultant-led teaching, full day program focusing on medical students and the orthopods of the future. So after that, without further ado, we'll get cracking on our teachings. We've got Mr. Ranway, who's the current BOTA president, and Mr. James Tomlinson, who's a spinal surgeon, to talk to you tonight about Cauda Equina syndrome and the management of C-spine fractures. So over to you, James.
Thank you. That okay? Perfect. Big topic this. Thanks for the invite to speak this evening, and welcome everyone. If anyone wants to ping any questions out with the Q&A or ask anything about the talk, email and Twitter are there. Feel free to get in touch outside this forum if helpful. I've tried to break this down into 3 areas. So we're going to talk a little bit about assessment, a little bit about imaging, a little bit about basics of spine management. I think the complexities of what is and isn't a stable and unstable C-spine fracture, and what doesn't need surgery, and what type of surgery is probably somewhat beyond the scope of this evening. Quick thing to think about in terms of C-spine trauma. Common, especially in high energy mechanisms, why the C-spine is very mobile, and unlike the thoracic spine, which is fixed because of the rib cage, and the lumbar spine, which is relatively well protected, less protected, and also the head acts as a very big pendulum. And there's kind of almost 2 bits of the C-spine in terms of injuries. There's C0, C1, C2, so the axial spine, and then C3 to C7, the subaxial spine. Probably one of the key things really, especially at your stage and at any stage really, in terms of management of C-spine, mechanism of injury, really, really critical. So broadly, high energy, low energy, more specifically, real details of mechanism. So as an example, if someone's dived, we see a few of these every year, dived off a trampoline or into a shallow pool, hit the head on the floor, often see a forced flexion injury, classic mechanism for a bifacet dislocation, fall from height, with axial loading kind of straight down onto the head, classic mechanism for a C1 fracture. But the mechanism will often give you a huge amount of clues as to the likely injuries that you're going to see. And as we'll mention in a second as well, that depending on whether it's high energy or low energy makes a big difference in terms of imaging as well. The one thing out with that, which is a whole topic in itself, and we can't go into this evening, but elderly patients, the most common cause of C-spine trauma in an elderly patient is a fall from standing height. So you need to be really careful that even low energy mechanisms in the elderly can cause very, very significant injuries. In terms of, I suppose, again, at your stage, things to think about, where these are high energy injuries, these patients should be getting a trauma scan. So the big things to be thinking about are what are their other injuries in terms of whole body, and also what are their other spine injuries. If you've got a C-spine fracture from a high energy mechanism, you've got a 20 to 30% chance of having a fracture at another level in your spine. So as a bare minimum, these patients should be getting a trauma CT. Other key bit of assessment, once you've thought about mechanism and other injuries, and obviously the thing I haven't mentioned there, which I should mention, is obviously a lot of these patients need management according to ATLS principles. Documentation of neurology is absolutely critical in these patients. Two reasons. One, often in polytrauma patients, when there's medical legal issues, from a spine point of view, it's around clarity of documentation. And it will say neurology grossly normal, moving all four limbs, and someone says, well, that doesn't actually prove that at the point of this person seeing them, the neurology was normal, and we know it wasn't normal later on, but what we don't know is when it became abnormal. And so detailed neurological exam is critical. And it's really helpful if whoever's doing it writes, rather than writing C5, 5 out of 5, C6, 5 out of 5, writes specifically what joint you examined on what side. And the reason for that is different texts and different references quote different muscle groups for particular myotomes. So if you write C5, 5 out of 5, C6, 4 out of 5, and someone else comes along and thinks C6 is 5 out of 5, the immediate question is, well, did you examine different things, or did you examine the same thing and found a different level of power? Why does that matter? In terms of assessment of a spine, if their patient's neurologically normal and they've been normal throughout, as a general rule, no need to panic. Tomorrow morning, things can be sorted. If there's abnormal neurology and it's static, and again, key detail here is what happened at the time of the accident. If it's, I couldn't feel anything below C7 from the moment I hit the ground and it hasn't changed since, it's not great, but it's less of a concern. If it's, I could move my arms and legs and then things went tingly and now I can't really feel anything below my shoulders and they suddenly can't move their legs and they've got progressive deteriorating neurology, that is an absolute spine emergency, because it means they've either got dislocation or deformity causing cord compression, or they've got an expanding hematoma, and both of those things need addressing immediately as an emergency procedure. Something to kind of bit of homework that's worth having a look at. There is a nice guideline on spine injuries and assessment and management, and particularly with reference to imaging. It's very detailed, it's very good. It had a lot of very senior people involved. It's well worth having a look at that. In terms of imaging, you'd obviously normally get a trauma scan in these patients, and the key, if you're in a trauma centre, this should happen automatically, but the key from a spine point of view is you want coronal, sagittal and axial reformats, because you need to look at all three. And as a general rule, you're looking for bony abnormalities. So on the sagittals at the top there, so are the displacements of the lines running down the front of the bodies, back of the bodies, along the spinous processes? Are the facets displaced, as you can see there? What's on the axial? Is there a burst fracture? Are the posterior elements intact? And then on the coronals, is there anything that you haven't seen? Peg fracture, far more obvious usually on a coronal image. Anything that you haven't seen on the other images. But you need all three, and you need to go through them in detail, because sometimes things can be quite subtle. Obviously, there's some examples here of not so subtle injuries. MRI, when do you do that? So takeaway message, if you've got abnormal neurology, whether it's static or progressive, that's a reason to do an MRI. More subtle, sometimes going back to this injury, you may sometimes see a subluxed facet that isn't fully dislocated, but in the absence of a fracture. So if you think there's displacement, or sometimes you may see widening of a disc space on a CT, any kind of hint of displacement or distraction without a fracture, there's a role for MRI to look at the soft tissues. That's probably not something to do in the heat of the moment in the middle of an A&E trauma call. That's probably more something, unless it's for neurology, that the spinal surgeon's going to discuss the next morning, because some of that will also be what sequences they actually want and what they're actually trying to look for on those sequences. And then in terms of treatment, this is the kind of, remember when you guys were all lazy teenagers wanting to lie in bed all day, or medical students like I was. If in doubt and that you're concerned about the spine, leave the patient, as a general rule, leave the patient flat, don't move them, is pretty safe position. Other things in terms of emergent management, really, really critical. Make sure the patient's well oxygenated. That's probably going to be happening anyway as part of their trauma care. Make sure someone's monitoring their blood glucose. make sure they've got a catheter and their bladder's decompressed, and you're monitoring their fluid input, output, and that you're maintaining organ perfusion. About 20 to 30% of patients with a cord injury will extend their cord injury to a more proximal level. And by oxygenating patients, keeping them well perfused, keeping their blood glucose stable, not mobilizing the spine any more than strictly necessary, you can try and limit the degree of secondary cord injury. And that's critical because an ascending cord injury may start to become the difference between, there's a patient with a cord injury who can use a powered wheelchair or even a manual wheelchair, which as the cord injury ascends may become, actually can't even use the powered wheelchair, or if a cord injury ascends very high, may start becoming, can't use a powered wheelchair, may becoming ventilator dependent. So what happens when these patients land in A&E and for the next 24, 36 hours can still have a big impact. In terms of treatment, again, I would be happy for someone at CT level to do this if I've worked with them on a regular basis. Ideally change extraction collars to an Aspen collar as soon as reasonably possible, or some other form of semi-rigid orthosis. Extraction collars are really, really horrible things that very quickly cause pressure sores. And then in terms of treatment options for these injuries, obviously things you may see, collars, halo vest, traction can be used. Again, not something we expect you guys to be doing, or fixation, which may be anterior, posterior, or both. As a general rule, in the emergency setting, keep the patient flat, put a collar on, fine, and then give them some oxygen, wait till the next morning. There's one trade-off with keeping patients flat is obviously a lot of these will be polytrauma patients. So if the anaesthetists and the cardiac surgeons are saying, no, actually, if you keep this patient flat, the chest injuries are going to kill them, we want to sit them up to 45 degrees. Well, you have to have a degree of compromise, and it's about finding the safe position that gives the best compromise for all of the injuries present. And then in terms of things you may see, I think the other thing just to say, I've put this in deliberately, often when you're a fairly junior, including me when I was a year 1, year 2 registrar, you look at a CT like this and think, oh, that's absolutely terrifying. Burst fracture, single column injury. This patient was neurologically normal, no other injuries, put in a collar, treated for 3 months in a collar. This fracture remodeled, and 3-4 months down the line, this had healed, and this will remodel over time. So things that look scary aren't always scary. Again, put them in a collar, sit them up, wait till morning. And then in terms of, I suppose, things to be wary of, you saw one of these earlier, but this is a sagittal slice on the left from a bifacet dislocation, and then a post-op image of the dislocation reduced and fixed, as well as patients with progressive neurology. If you see a patient with a bifacet dislocation, and the clue to start looking for that is usually there'll be at least 50% or more translation of the vertebral bodies. Even in a neurologically normal patient, that is a spine emergency. So if someone's got a bifacet dislocation, I want waking up at 3 in the morning and I want to know about it, even if they're neurologically normal, because these patients can go off very, very quickly. So in terms of key takeaways, probably main things for you guys really at this stage are spinal cord protection is absolutely crucial. So even if they've already got a cord injury, try and prevent further injury, oxygen, careful monitoring of blood glucose, and try and minimize movement of the patient, both movement between wards, movement, log rolling for assessment, do everything in one go. CT if high energy injury. And the other thing I'd add to that is in elderly patients with low energy mechanisms who are not cognitively normal, I would always push for a CT C-spine. I've seen more than one C-spine dislocation in an elderly patient who was not complaining of neck pain, who was known to have dementia, and then you CT them and they're dislocated. And sadly, some of those patients, those dislocations are missed, and the first time it's picked up is when the patient becomes paralysed on a ward 3 days later. Progressive neurology or bifacet dislocation, absolute emergency. Someone senior needs to know about it. And if you're unlucky enough to be in a centre where there isn't a spinal surgeon on call, get hold of one quickly, get hold of seniors, get them to get hold of someone. And that's a whistle-stop tour of C-spines. Thank you.
That was fantastic. Thank you very much. We'll give it a couple minutes to see if we've got any questions. In the meantime, I've got one.
Yeah.
So with regards to the facet dislocations, what are your thoughts on timing regards to MRI and closed reduction? Because I know there's various thoughts on MRI before or after closed reduction attempts.
There's a can of worms. Controversial is the easy answer to that question. So driven by, if you've got progressive neurology or abnormal neurology, you need to operate anyway. So some people in that setting would say, why do an MRI? You need to just go to theatre, open that up from the front and reduce it. And so doing an MRI isn't really going to add anything. If you've got a neurologically normal patient or a neurologically static patient, and the other thing that will drive it is access to MRI. That I'm lucky enough to work in a centre where if we ask for an urgent MRI, we'll get one in 60 minutes between 7 a.m. and 10 p.m. If you can get an MRI quickly, I would do one in a neurologically normal patient. The reason for that is you want to know what the disc is doing. And if the disc is injured and in the canal, you don't really want to reduce that unless you want to. If you are going to reduce it awake with weight, you want to do it in theatre so you can immediately operate. If you start reducing it, the patient says my arms are going tingly, because the risk is the disc compresses the cord in the canal. But it's a hugely controversial. Again, it tends to be driven by centre by centre. In the UK, there are some centres just wouldn't MRI at all. There are some would MRI most. There are some would MRI some.
Great, thanks. I think we've only got one other question, which I think you sort of kind of answered. Is there anything preventing reduction and fusion from the back in a bifacet dislocation? And I think the answer is the disc.
Yeah, if the disc isn't in the canal, no. The reason certainly I tend to do them from the front is it's just a much more elegant operation. There's a lot less muscle dissection. There's a lot less post-op morbidity for the patient. Posterior C-spine wounds, particularly in the setting of trauma, are renowned for wound healing problems. So if you can, I'd stay away from the back. In elderly patients, you may need to do front back because the bone quality isn't good enough to do one or the other.
Great, thanks. So I think in the interest of time, we'll move on to Ran and his talk.
Thank you, James. And that's fascinating, actually. I kind of wish I heard that before my exam. Here we go. Hi, everyone. Can you see my slides there?
Yeah, all good.
Hi, everyone. As George said earlier, my name's Ran. I'm the current BOTA president, and I'm honoured to be given this opportunity to present to you about Cauda Equina syndrome. It's quite hard to follow after James, given he is a consultant spinal surgeon, but I'll try and do my best. And hopefully James will help me field some of the questions that you'll inevitably have about this really important topic. So just want to go through the anatomy, the pathoanatomy, clinical features, a bit about imaging and management, some of the evidence surrounding management, and then talk a bit about the pitfalls, which I think you really ought to know about. So in terms of anatomy, I hope none of this is news to you, but certainly from medical school, we're all taught that the spinal cord finishes at the L1 level. Clearly there are anatomical variations, but generally speaking, we quote L1 as the point of the end of the spinal cord. So the Cauda Equina, or Latin for horse's tail, is made up of the nerve roots of L1 to S5. These clearly are lower motor neurons, and therefore compression or lesions of these nerve roots will give you lower motor neuron signs. So it's important to know about the exiting and transiting nerve roots in terms of relation to the disc. So here you can see that the L4 nerve root comes underneath the pedicle of L4, and the L5 nerve root comes under the pedicle of L5. Slightly different in terms of where they come out and in relation to the pedicles compared to the C-spine. but this can, and obviously this can cause a bit of confusion as well. And certainly it's one common question in MRCS that they ask, well, they used to ask. So the way I used to remember it is that the S1 always goes through the S1, the sacral foramen, and therefore L5 must go underneath the L5 pedicle and L4 underneath the L4 pedicle. Now, why is that important? Well, if you've got a disc that is protruding paracentrally like this, that's not going to take out the L4 nerve root, as you can see there, whereas a lateral disc will. And what the paracentral disc will take out is your transiting nerve roots, which could either be the L5 or the S1 nerve roots. Clearly, a central disc can take out most of the nerve roots and the contralateral side as well. So in terms of the disc anatomy, again, I won't bore you with this. All of you should know that there is a nucleus pulposus and it's surrounded by an annulus fibrosus, and this really allows some dynamism within the spine and between the spinal segments. Obviously at the front you've got the disc, and the back you've got the two facet joints, and it responds well to compression. But when you've got fissuring of the annulus fibrosus due to degeneration, then you can get leakage of the nucleus pulposus and therefore a disc prolapse. So why does Cauda equina syndrome happen? Well, it can happen, well, this is the way I've classified it. It can happen due to mass effect or a malalignment. The most common reason is disc herniation. So you can see here, and this is normal anatomy. This is a paracentral disc compressing on unilateral nerve roots. And obviously this is a central disc compressing on the Cauda equina. But this isn't the only thing that pathology that can cause Cauda equina syndrome, although rare, but spinal stenosis can cause Cauda equina syndrome. So spinal stenosis is a degenerative process. It tends to happen over a number of years. What happens is the disc becomes degenerate, you lose the disc height, the facet joints become arthritic, and because of that loss of height, you get infolding of the ligamentum flavum, and then you can have stenosis or a tightness within the canal that the nerve roots run through. And as you can imagine, that will cause compression of the nerves. But clearly this is a chronic process and usually doesn't happen acutely, and therefore the nerves respond slightly differently to this pathology. But what can occur quickly that compress the nerves are tumors. So obviously in the spine, you can have both primary and secondary malignancies. And it's clear here that a tumor can cause pressure within the spinal canal, both at the cord level as well as the Cauda equina level. You can get epidural hematoma, and this can be iatrogenic from a spinal anesthesia, or you can get abscesses. And obviously the thing that comes to mind, or should come to mind when you ever hear an epidural abscess, is TB, and that's something you have to keep in mind as one of your differentials. Trauma can cause a mass effect as well when you have a retropulse fragment, but also can cause malalignment. And in severe cases, when you have something like a pars fracture, that can give you a traumatic spondylolisthesis. So you get shift of between the spinal segments, and that's obviously going to have quite a significant effect on your nerve roots. So just a quick recap, and I hope I don't mean to patronize, but obviously I want you to get clear in your mind that what a syndrome is. And a syndrome is a group of symptoms that's consistently showing essentially a disease. So Cauda equina syndrome, you really need the symptoms. So you can have a MRI showing a huge disc compressing on the Cauda equina, so the nerve roots, but the patient may not have any symptoms, and therefore that's not Cauda equina syndrome. I just want you to get that clear in your head. So don't treat the scan, treat the patient. So what happens from a biological level? Well, when you have compression of a nerve, or the nerve roots, you get decreased nutrition going to the nerve roots, either through decreased blood flow or decrease in the CSF diffusion. That then causes somewhat of an intraneural compartment syndrome, subsequently causes venous congestion and more edema, and then ultimately nerve root or nerve ischemia. And that is a process, and that's a spectrum, and hopefully you don't want to get to the point where you have nerve root ischemia. So what are the features? Well, back pain is a predominant feature, but clearly back pain has a myriad of causes, and Cauda equina syndrome, although our colleagues in A&E may feel like is the only diagnosis to back pain, you have to take a decent history and examine the patient to ensure that it is not just a mechanical back pain. So the patient will exhibit usually bilateral radiculopathy, and certainly that's one of your red flag symptoms of bilateral leg pain. But they can also have unilateral leg pain, and that can signify incomplete Cauda equina syndrome. They often will have sad anesthesia because the nerve root supply and the sensation in the perianal region would be compressed and undergoing some form of pathology. They may have impotence, but again, patients aren't going to offer that willingly, so you've got to ask. They will likely have some form of sensory disturbance in dermatomal distribution, and also weakness in a myotomal distribution as well in the lower limbs. They can, and obviously this is a worrying feature, is a neurogenic bladder, and it's important for you to understand it's overflow incontinence, which means that the bladder cannot empty, so it goes into retention. So it's usually painless retention, and subsequently it overflows, and that's due to disruption of the pelvic splanchnic nerves, the inferior hypogastric plexus, which supply the detrusor muscles, and as well as the pudendal nerve that supply the external sphincters for voluntary voiding, and that obviously in itself disrupts the whole bladder reflex arc. And I think it's important for you to know as well that fecal incontinence is actually quite a rare symptom of Cauda equina syndrome. Clearly, it's a significant symptom, but it's a rare one. In terms of examination, well, certainly the patients I've seen before with true Cauda equina syndrome have not been walking around or sitting up in the chair. They've all been lying down in bed in this considerable amount of pain. So you want to certainly palpate the abdomen, and that's to see whether they do have a painless urinary retention. But also you want to check that there's no abdominal aortic aneurysm, because anyone presenting with back pain, you have to rule that out. You want to do your normal neurological examination. Obviously, you'll have your own way to do it, but look for weakness, whether it's unilateral or bilateral. You can use an Asia chart to help you out with this, to keep you make sure you don't miss anything. But as I said, this is a lower motor neuron lesion, and therefore they will have absent reflexes. They may have reduced or even absent sensation in the dermatomal distribution in the lower limb. They may have sad anesthesia, and obviously that's a very worrying sign, one of your red flags. So make sure you test for that, and it's usually it's pinprick that you test for, not light touch. You want to do a PR, although I've always found checking for anal tone not very useful, but certainly voluntary contraction is useful. Probably the most useful bedside test would be a bladder scan, so post-void residual volume bladder scan. And there's an excellent paper published in 2019 that shows that the negative predictive value of a post-void residual of less than 200 mils is around 97%, and that's great. So it means that anyone that's got a post-void residual of less than 200 mils, you can be a bit less worried. But although if you've got a lot of the salient features, you still need to get a scan. So what imaging do you need? Well, if they've got a history of trauma, then I would certainly do an X-ray, albeit you might come across some difficulties in radiology departments, but there's lots of things you can pick up on an X-ray, such as the alignment or any presence of a sclerotic or a lytic lesion. Obviously, the investigation of choice will be an MRI scan. So obviously, this is an axial T2, and this is a sagittal T2, showing quite a large disc at the L4-5 level, which is the most common level for a disc prolapse. And on that, you can obviously have you have lots of slices you can look through to try and discern exactly what the pathology is. If patients cannot undergo an MRI scan because they've got a cochlear implant that is not MRI compatible, or they've got any foreign bodies that are not MRI compatible, then you can consider a CT myelogram. But obviously this is center dependent, and you really need the expertise for this. You need to find a radiologist that can do this. So in terms of management, it's quite a busy slide, but effectively the take home here is that if you've got a negative MRI, obviously you can be pretty happy that there's not much that you need to do apart from analgesia, reassure, and ensure they've got adequate follow-up, because patients with back pain or even unilateral radiculopathy will require some form of management, either with the pain team or physiotherapy, or even follow-up in the spine team if they do have quite severe radiculopathy. Patients with suspected Cauda equina syndrome, where they've got bilateral radiculopathy and an MRI showing a large central disc. Well, this is quite a controversial area, so the patients need to really speak to a spinal surgeon about this, either orthopedic or neurosurgeon, and discuss the merits of undergoing a operation to decompress the disc. And this is really just to potentially avoid it progressing onto an incomplete Cauda equina syndrome, where they have urinary disruption, urinary symptoms. And when they do have urinary symptoms, that becomes an emergency, and really patients really ought to have their operation within either that day or that night. But again, there is some controversy surrounding the timing as well of surgery. So these three here, it's not gospel, but certainly what you want to take away from this is that if you've got symptoms and signs of Cauda equina syndrome and an MRI scan that's proven it is, the patient needs to have a decompression urgently. And therefore, if you're in a centre where the expertise is not available, they need to be transferred out to a centre where the expertise is available. So just to give you a bit of context, and I'm sure the vast majority who have done SSO on-call shifts will have come across patients with back pain. And unfortunately, even the most convincing patients with symptoms and signs may not end up having an operation. So don't be disheartened. And that's just the nature of some of the controversies that surround this very litigation-prone topic, and this sometimes hazy disease. Patients, just remember that patients can progress from one subgroup to another. It's a spectrum, and therefore they often will require some form of monitoring. And ultimately, if you're not in a centre that can cope with these patients, they need to be transferred to a centre that can, or at least get advice from a centre that can. If they've got incomplete Cauda equina, then their outcome in terms of sphincter control is actually quite good, whereas they've got retention at presentation, then their outcome clearly is less good. So what surgery can we do? Well, the main ones are microdiscectomy, and so there's a sort of image diagram showing what essentially we do for microdiscs. So you go through a laminotomy, so you go through a lamina, make a hole, take away a bit of the facet, so do a facetectomy, and then you do a decompression of the disc extradurally, so you move the dura out the way and sneak underneath the nerve root there to decompress the disc. Or in cases of spinal stenosis or even significant discs, you can do lumbar decompression. So that's a laminectomy. So that you can see the lamina here gets taken away and the spinous process. And actually, you can take away 1 or 2 levels of spinous process without actually affecting the stability of the spine. So pitfalls, lastly, certainly this is one that I've come across twice in my last 8 years in orthopaedics, and it's one not to miss. And really that's just depending on your history, your examination, because when you do a PR, you will feel mass in the rectum if they've got a chordoma. So it's important not to miss that, because as you can see here, this is an MRI scan showing a relatively normal lumbar spine, but actually if you cover the sacrum, you can see there's a huge chordoma, which is the most common primary malignancy of the sacrum, and this patient's not going to do well, unfortunately. Clearly, if you've done all your due diligence, you've done your history, you've got examined the patient, you've got a scan, and there's nothing there, then it's important to consider the yellow flags as well. Clearly, this is something that you consider after you've ruled out the salient points or the emergency issues. And these patients are really difficult to manage when they have these yellow flags, and really it's an MDT approach, and you really need help then, because often they can sit in your ward for quite a while with pain and that you can't control. Lastly, litigation is a high litigation subject. So between 2003 and 2008, I think these figures were, the average payout was over 200,000. I think it was one case that was over 2 million. So it's not one to be missed, and actually it is much cheaper to get a scan than get sued for missing a Cauda equina. So that's one of the takeaway messages as well, I guess. So hopefully with all of that information, you would be able to now manage and review and manage patients with suspected Cauda equina much better during your on-calls. And I welcome any questions. And just a last plug, I know George has said that already, but please do join us for our Congress this summer. It's going to be brilliant. We've gone with quality rather than quantity, and we're going to deliver some excellent education material. And do visit our website. And obviously, if you fancy joining the committee, then please check out our committee page as well. And it may be you on the committee next year. Thank you.
That's great. Thanks, Ryan. I'm not sure if James was...
Yeah, I think James might have gone to see the little one to bed, I guess.
So there was one question not related to Cauda equina.
I am still here.
Oh, yeah.
Fab. There was one question not related to Cauda equina, but was what's the current thinking regarding IV DEX for traumatic cord injury? Certainly from my reading around for the exam, I found that the evidence says that there is no proven benefit and potential harm can be caused. Is that correct thinking?
Absolutely. Basically, don't do it. Exactly that. It doesn't do anything useful, and it does cause harm. If anyone's interested, the studies are the NASCIS, NASCIS studies. There's several of them, which were done in the US a few years ago. They're the ones to know about steroids for cord injury. But as per that comment, if it's metastatic cord compression, that's a totally different thing and should give steroids. But in trauma, no.
I don't think
anyone really a bit of a spine geek, the kind of emerging area of interest in acute cord injury is whether there's a case for emergency durotomy and evacuation of hematoma from the cord, but that is very much experimental research work at the moment. I mean, the implications of that, if it does work, are not great, because people are going to getting up at all times of night to open cord up and evacuate hematoma. I might become a hand surgeon if that's a thing.
Great. Well, thank you both for your time. I've got no further questions, so I think we'll just end things there. One message just coming through at the final gate. Someone's asking about sodium channel blockers for spinal trauma. Can't see that's something
That is something I have not come across, and certainly not something in routine UK practice is the easy answer to that.
Fair enough. Well, thank you both for your time. We'll end things there and hopefully enjoy the rest of your evening.
Thank you.